to attend, and our mirror board has a standing invitation to attend as well. We will also have our mirror board colleagues, Aminata Collin and Stephen Roots, for one of our agenda items in leadership and culture. Thank you to both for joining us. Can I move us then to our conflicts of interest register? Is there anything new or relevant to today's meeting that my board colleagues would like to update? I see no hands on there, so thank you. Minutes of our last meeting held on the 21st of May and matters arising. Have any comments or questions? Okay, thank you. So let's move then to our first agenda item, and that is our Chief Executive's update from Fiona Edwards. Over to you, Fiona.
Hi, hello everyone. I'll keep it brief as we're a short meeting today, just to really reflect and thank the team and staff on the scale of internal reorganisation that's being implemented in the Integrated Care Board, and we're moving through that towards the final stages, but a huge amount of work being done by the leadership, but also support from staff and staff representatives through that process to make what has been a challenge to reduce our cost base by 30% as smooth as we can, and we're nearing completion, and we're certainly on track to deliver those savings as well. Our performance in the first couple of months of this year has started in a reasonably strong place across the system from a health point of view, built on strong partnerships around UEC and strong performance of our acute partner in waiting list management and recovery. That still doesn't mean to say we do have still, though, an unacceptably long waiting list, and people in our communities do experience that. I'm not saying that doesn't exist. I'm just saying that we are making inroads and progress in addressing that. We've obviously had a change of government, and we are engaged with thinking through and ensuring we can engage with any change in policy direction, but also really focusing on delivery and improvement against our constitutional standards for the public in that space. And we are continuing to be a key partner across health, both with neighbouring systems and regionally, on a number of pieces of work to improve the connection and delivery across the South East, and as a system that has a delivery record in transformation and innovation, and particularly with our digital underpinning. So I'll stop there, Chair, and take any questions if anyone's got any.
Thank you very much. Comments and questions for Fiona? Thank you. I'm going to ask now for our agenda item on leadership and culture for Safina Nadeem to lead on this. This is part of our work, really showing how we live our values. And so over to you, Safina.
Thank you. Ollie, I don't know, could you put, yeah, perfect, thank you. So as Priya said, this is kind of a part of our ongoing commitment to cultivate the zero tolerance environment and creating them respectful and safe environments for our people. So this statement was co-developed with our equality staff networks and our staff in the ICB. And it's really kind of giving clarity around what are our expectations from people when we work with them around unacceptable behaviours, and giving that kind of a culture of of accountability for people when they haven't said the right thing and how we can respond to that. So it was lots of engagement around with staff developing this, and it kind of really builds on the work that we're doing across our ICB and creating cultures of inclusion. People feel that they can speak up, raise concerns, address microaggressions. So there's lots of work underpinning this that's happening, and lots of resources that will help staff understand what's acceptable, and more importantly, how do we challenge inappropriate behaviours. So hopefully the statement is self-explanatory. The statement was discussed at the Mirror Board meeting last week, and overall the kind of positive feedback from the statement, and people really happy with the commitment of the ICB to have a zero tolerance against any kind of unacceptable behaviour, bullying or harassment. Some of the points that they raised in the Mirror Board, and I'll let Amy and Stephen come in as well, said it was really good that we have a statement, but really more importantly, what action is taken when people are not aligning their values with what's expected by them. So that was some of the comments that came back, and also how do we use this in practice? How do we kind of make, what are the examples we can use this in terms of when we're working across our system, in GP surgeries, when we're working with our partners, how do we use this? And there's some work that's happening that's going to be underpinned with the statement as well to help put that into practice. So I'll ask Amy or Stephen to with any comments, and then if anybody else has got any thoughts, that'd be great.
Thank you, Safina. I'll just add on to the patient aspect part of it. So we did consider that the patient is also important. Well, our business is to do with patients and not both their well-being, safety, as well as the staff that we have. So we thought that it was really important to have the mechanisms in place so that they can safely report both the patients as well as the staff around zero tolerance when inappropriate behaviors take place. We thought it would also be important to ensure that we do the appropriate training for the all involved, because once we train people, then they know what is expected of them, and therefore we can have accountability measures. But without training people, then we cannot have those accountability measures in place. It's important to consider all aspects of legal and ethical standards around this as well to make it just robust, the framework that we're going to make. Yeah, I think that's the part of it's important in terms of handling the reports as well, and the reports that are coming in, that so that people have trust in the system. I'll just let Steve come in on the other points.
Thank you. I was looking at a little bit from the psychological safety point of actually the courage it takes to people to actually raise some of these concerns around these things, and sometimes they get raised in quite a challenging way because actually it's taken lots of courage in someone to actually get to that point of raising it. And so I think we need to remember about how we recognize when someone's raised something, that actually there are two sides, and actually we've got to be fair both sides. But also there's sometimes around that intention. Was it intended or not? And that may look as actually that goes down more of the formal route. But a lot of this is around behaviours and relationships, and how do we look at more of a restorative approach around learning and actually trying to work through that process of that challenge. But also it's recognising what concerns are being raised, but also where are those areas that the discrimination or some of these challenging behaviours are happening that we're not hearing, particularly around some of our minority groups or some of our areas that perhaps feel discriminated and actually feel that fear or futility of speaking up about it. So it does bring a lot of challenge around it and how we hear them, but then how do we look to address them in a fair and open way?
Thank you very much. Davina, will you come back in?
Yeah, yes, I think, did we have, I thought Sarah was going to come in. I thought I saw Sarah.
Yes, come on in, Sarah.
Thank you, Sabina. We really, really welcome this, because I think actually the staff are our greatest asset in our NHS, and the importance for delivering fantastic outcomes for patients. And we have to make all staff need to be able to feel valued and confident and be able to feel safe. when they're undertaking their role. So thank you, Savina.
Thank you, Sarah. Shall I open it up now, Savina, to comments and questions? Brilliant. Okay, fantastic. Thank you. For colleagues on the board, can I ask for any comments and questions, please? I'll start actually whilst we're waiting for others to come in, but just to say how positive it is, the work that got us to this point, because it's as important for us all to hear it as it's being developed as it is to see a statement when it comes out at the end. So really fantastic to see the work that's gone into getting us to this point. So thank you very much. And that clear tie to safety and best outcomes. So thank you. Good. And thank you to the Mirror Board for their time in considering this as well. I'm going to move us now to our integrated performance report and ask Richard Chapman with Sarah Bellas and colleagues to take us into this item. Thank you.
Thank you, Chair. I'll take you through the finance and performance presentation and then hand over to Sarah to add her report on quality. So if we can just move on to the next slide, Sam, if that's okay. Thank you. So at month 2, the system financial position, remembering that the technical constituents of the ICS are Frimley Health, FT and the ICB itself. So the system position was £900,000 adverse to plan. The variation was driven by pay costs at FHFT and non-pay pressures in medical services, drugs and clinical supplies, reflecting high levels of activity in the system, which themselves are driven both by urgent emergency care demand and elective recovery efforts. There is some risk in the CHC position within the ICB, where providers are reporting cost pressures potentially in excess of the funded and agreed 4.1% uplift that has been applied to contracts. But good news in that agency costs at FHFT continue to fall, being £2.5 million below the same period last year, which itself was materially below where it was in the 22-23 financial year. If we just move on. Thank you, Sam. So these slides summarize the financial position by portfolio. So you will see the various different elements of the wide range of activity that we undertake. If you move on one more slide for me, please, Sam. Thank you. And again, kind of demonstrating the grip on the different portfolios which are across the health and care system. And one more for me, please, Sam. We'll move on to one more again. So thank you. So this slide summarizes primary care. You will see a common theme. I'm going to talk about primary care, urgent emergency care, and diagnostics and cancer on these 3 slides. You will see a common theme of relentless pressure throughout the system in terms of demand for healthcare. So in primary care, we see 83% of appointments in primary care were the same or next day, and 90% within 14 days of booking. Those figures compare to 77 and 86% respectively for the same period last year, and are amongst the highest both in the South East and I believe nationally. There are some specific issues around which are being addressed around the modern general practice access model, which facilitates the prioritization of appointments being booked, and adoption has been agreed as a shared priority for primary care and digital primary care, and a plan will be developed together over the next 4 to 6 weeks to address those issues. The system remains below the England average for face-to-face appointments, again reflecting digital access and the counterplay between face-to-face access and same-day appointments. If I can move on one slide, please, Sam. Thank you. So urgent emergency care, so urgent community response, the high levels of referrals and appointments and good performance in that 82% of referrals were seen within 2 hours in April. On ED 4-hour waits, we are not at 78% yet, but last week we broke 80% performance 3 times, which is encouraging, and we are working particularly closely with colleagues in acute to improve type 1 performance. And last slide, please, Sam. This slide covers diagnostic 6-week waits and the 62-day referral to treatment target for cancer. There is some positive news there in that total patients waiting for diagnostics continues to fall, and we now have in situ and mobile MRI, which is responsible for an extra 400 scans per month. And on the 62-day wait, we will see that the performance in April was 73%, with over 300 patients per month receiving their first definitive treatment within 2 months and exceeding the target of 70%. I'm going to stop there. Share, Sam, if you wouldn't mind stopping sharing, and I'm happy to take any questions.
Thank you very much, Rich. Can I open up, please, to comments and questions? And if not, I'll ask Sarah, please, to include our quality report. Thank you, Sarah.
Thank you. Ollie, I think, is going to project for me, and we're going to start at page 9 because I've got some interesting information for you on medicines optimization and AHP work that we're doing, but really wanted to talk about some of the quality and safety issues that we're working on across the system. So Ollie, if you could start us at page 9, that would be lovely.
Sarah, you're quite could you speak up a bit or come closer to the mic?
I'll get closer to the screen. Sorry about this.
Thank you. That's better. Thank you.
Have we got to slide 9? Nearly. Okay, so I wanted to start with adult eating disorders. As we previously reported, there was a gap in provision for people waiting for services, for adult eating disorder services on physical health checks. This was a risk area for us. We have worked with local providers and have commissioned a service, and we're aiming for the service to be initiated sometime later this month, and it's still on track, is my understanding. If we move to the next slide, please. There's been a bit of an increase in infectious diseases that people have probably heard about. We've seen an increase in measles. We've been working with primary care to vaccinate as many people as possible, and also their preparedness for dealing with any cases, ensuring that they've got the right protective equipment and the right facilities to minimise any further spread of infection. Pertussis or whooping cough, there's also been a national increase in this area of this, and we're again working with the teams to help improve the uptake of the pertussis vaccine, including of pregnant women who can have it from 16 weeks, and we're working with our maternity department to try also to increase that for pregnant women. Another vaccine that we're introducing that isn't on the slide because it's new, since some of the information is newer than when we produced the slides, is an RSV vaccine that will be available to pregnant women from 28 weeks of pregnancy in September. So we're working to make sure that we also get that respiratory illness is common in children and causes lots of admissions to hospital. So it's really important that we try and vaccinate as many of those women in order to protect those babies when they're born. Can we move to the next slide? You may or may not notice that there was some press around a CPE outbreak that our local acute trust has been experiencing. This is a common organism that's seen across many organisations across the country, and actually our local trust has been working really proactively on trying to minimise this, and then perhaps maybe been a bit of out of context description of it, which is why I've included a slide on it. So CPE is a carbon, I'll never say this correctly, carbapenemase producing Enterobacterales, lovingly known as CPE. The outbreak has spanned a significant period of time, 75 cases. It's known cause of hospital-acquired infections globally. This particular infection is associated with water and drainage systems, and the Trust has been working really proactively with both regional, national and international colleagues to see how we can make difference in it, and they're looking at some environmental changes, including some changes to some sinks. And I was fortunate enough to go and visit the unit where they're looking at doing it and have it explained in person and understand these new types of sinks. It sounds all very technical and positive what they're doing, but the work with everybody. They carried out a formal review into the cause and the nature of it. They found that 4 people had died with CPE, but not as the cause. And so I think it was just really important that we brought that here to show how positively and proactively the organisation are working to try and minimise this. Can we move to the next slide? Just a little bit of update on the spring COVID vaccination campaign, which has come to an end now. Most of our PCNs and practices took up the offer. We had 58% uptake across all cohorts. This is much lower amount than we've seen previously. This is reflected nationally. I think there's a bit of vaccine weary around the COVID vaccine, so we need to think about how we might encourage people prior to the September uptake. And I think a lot of people have been suffering with COVID more recently, so hopefully that will help us. We move to the next slide. As part of this, we continue to utilise the Inequalities and Access Fund, and we funded a number of projects across the system to try and increase the uptake in areas where the uptake was specifically low. And as you can see, we had a Hampshire Health Bus, Slough Council for Voluntary Services with their community champions, and we had some community outreach events for the Gurkha veterans. So there was a wide range of things that we did to try and improve that uptake. Move to the next slide, please. Just really to let you know that the CQC have changed their assessment framework and are using a single framework now across. And you'll see on the next slide that they've outlined it as a pyramid, and this is their regulatory model that we're doing, and we're starting to see them undertake the assessments in line with this new model. We've been working with our providers, mainly the general practice, to help them understand the new model and prepare. Do you want to move to the next slide? This is the list of the providers that we've got across the system and their ratings. As you can see, the majority of our providers are good or outstanding. We move to the next slide, please. I just wanted to give a little bit of update about safeguarding. We've got our safeguarding training figures for you that you can see. We looked at we've just published our child death annual overview, and we've looked at some of the things that we've done to try and prevent deaths and look at some of the deaths that we have had. We continue to concentrate on our water safety campaigns, and last year there were no deaths from rivers in our area, and we'd seen significant numbers in previous years. We had an increase in the number of perinatal deaths in Slough. There was a deep dive report by the Slough public health team, and there was no correlations found. And then the other area that we've had an increase in is around sudden infant deaths, or the SUDIs. So we've been working extensively to share information about unsafe sleeping practices, working with our multi-agency colleagues on how we've done that. And we're continuing to look at the child suicide, and that they've found that there's been an exploration of impulsivity and minimal warning compared to adult presentations, and they're looking at the impact of that and what actions that we may be able to take. There's other information that's on this slide that you're welcome to have a look at or ask any questions on. Do you want to move to the next slide? There's been a couple of changes in guidance. So the working together to safeguard children has been updated, and there's been a focus on the multi-agency safeguarding arrangements between the ICBs, local authorities and the police. They're trying to ensure that they get senior representation at that meeting. There is lots of acronyms, and I'm sorry about this, but the lead person for safeguarding for the ICB is Fiona Edwards, and she delegates that responsibility to me under the statute, and I attend the boards alongside our deputy chief nurse for safeguarding, who holds a designated statuses. Do you want to move to the next slide? The other information that has been updated is the strategic safeguarding assurance framework, and the main new responsibilities for the SAF, as we lovingly call it, is increased presence at system-wide children safeguarding prevention groups, such as the violence reduction units and the strategic mapper boards and the community safety partnerships. Some increased reporting for safeguarding around different areas, and increased provider portfolios to include safeguarding for pharmacy, optometry and dentistry. Now, this has meant an increase in responsibilities for our team, when we've reviewed the team within the ICB against the framework and recognised that we needed to increase our designate capacity, and we have found a way to increase that designate capacity within the same resourcing budget, and that's been supported by the ICB executive, and we will make those changes to remain compliant with the statute and the frameworks. And I think that probably, do you want to just check if there's one more slide, or that was the last slide? Thank you, if there's any questions.
Thank you very much, Sarah. That's a very comprehensive overview there, very helpful. Comments and questions, colleagues? Thank you. I think that's been really helpful to see, and thank you to Rich as well for the overview of finance and performance. Thank you everybody for joining today, really helpful, and for all the work that's gone into both of those agenda items, and also for the progress that we're making in the way in which we serve our communities. Thank you to the Mirror Board for joining, and for the overview also of the zero tolerance work. Take care, everybody. Bye-bye.
Thank you.
Thank you. Bye-bye.